Thanks, Gavin. So as Ed actually raised, we need to start looking at some other important outcomes other than mortality. And so it's that area that I'm going to move into now and really focus on ICU recovery and what we've learned or what questions have been raised about that over the last couple of years. I'll start with a systematic review done by John Cresswell, just published this year, late last year, looking at ICU-acquired weakness and recovery from critical illness. And certainly in that, he clearly identified that our patients do have real problems with critical illness polyneuropathy, and we perhaps haven't recognised the extent of that in the past. In this study, or in this review, they identified about 10 predictive factors for poor ICU recovery in regard to the weakness. Now, if you look at that list of predictors of poor recovery, the first 5 or 6 of those are things that we can do nothing about. And so that, while it tells us which patients are going to have problems, it doesn't really help us in what we might change to try and overcome it. So it's the bottom predictors in that list, things like long duration of mechanical ventilation, immobility, hypoglycemia, glucocorticoids, and neuromuscular blocking agents. But the problem with that whole list is, as you can see, there's only 1 or 2 studies that have identified each of those. And many of those studies are very small, single centre, maybe 100 patients. So it starts to give us some hints, but it doesn't tell us a lot. And unfortunately, that's going to be my recurring message today. We've got some hints, but we don't know the whole story. Certainly in this study, cohort study, and there's almost no randomised controlled trials in a lot of this work, in this cohort study by Hermans, and that comes out of Europe, certainly they showed us that poor recovery is expensive, both for the patient individually from a physical point of view and also from a healthcare system financially. And so in this study, and it was a sub-analysis of a larger RCT, so they had 4,500 patients randomised to the larger study, which was about nutrition. And they looked at the subgroup that was still in ICU at day 8, and there was just over 700 patients. They excluded patients for various reasons, but mostly because they didn't wake. And so they had 415 long-stay patients, and they assessed them for ICU-acquired weakness at that point. 227 had ICU-acquired weakness and 188 didn't. And then they matched those patients on a whole range of variables, and you can see the factors there that they matched them on, and ended up with 122 matched pairs. So 2 groups very similar in terms of age, critical illness severity, diagnosis, those sorts of things, but different in their measurement of ICU-acquired weakness. And they looked at outcomes in that group of patients. And you can see there that on almost all of those outcomes, those that were weak spent longer in hospital, were more likely to go somewhere else other than home when they left hospital. And although the in-hospital mortalities weren't different by 1 year, the mortality was different. So what makes this group of patients experience weakness when they've been matched on all the other variables that we think matter? And so that's a study that starts to say, yes, we need to be taking notice of this, and yes, we need to be doing something to intervene to prevent it or minimise the weakness. And you can see there that the cost of these patients was about 23,000, this is hospital costs, €23,000 for the weak patients compared to 17.5 for the not weak. So what does this tell us? There's a significant group of patients that have poor physical recovery. There's certainly multidimensional predictive factors, and obviously we need to do something about it. As was the recurring theme in the sepsis session yesterday, we're getting a lot of the way to improving the mortality, but we need to be doing something about that 90% of patients who leave our areas alive but compromised. Okay, so if we are able to assess mobility, will that improve our ability to then put in place some interventions? And this is some work led by Carol Hodgson down here in Melbourne, where they've developed an ICU mobility scale and just this year published the feasibility and inter-rater reliability of that. The aims of the scale were to be usable by all ICU team members, have some content validity, be feasible, and have high inter-rater reliability across physios and nurses. This is an 11-point scale, and it just goes from being able to do nothing, in other words, lying in bed, up to walking independently without any sort of aid. When they looked at measurement, people who had assessed patients using this scale, they had 3 groups: senior physios, junior physios, and nurses, and they looked at how well each of those groups agreed with each other. There was great agreement between the senior and junior physiotherapists, and less good, but still reasonable agreement between the nurses and senior physios and the nurses and junior physios. So that's a beginning that we might be able to use to assess patients' mobility and agree that these people are the people that we need to get moving. Obviously something that still needs a lot of work to see what clinical application there might be. At the same time, over in London, there's been the Chelsea Critical Care Physical Assessment Tool developed, and there's been a couple of earlier publications in the 2011 and 12, and then this one this year looking at the construct validity of it. And this is a scale that uses 9 or 10 areas of activity, and you can see there the areas are all around the outside, so respiratory function, cough, moving within the bed, dynamic sitting, standing, sit to stand, etc. And each patient was rated from 0, not able to do it, to 5, able to do it independently. And you can see that red line around the outside that really quickly at a glance tells you for this individual patient, where are their problems, where do they need some assistance, where are they doing well. So if you look at this patient, you can see that in the sit-stand, standing balance, these sorts of areas, that's where they're doing least well, and that's where some interventions can be targeted for that individual patient. So this particular study, looking at the construct validity of it, looked at, is it useful for predicting where the patients go when they leave ICU? Does it predict their ongoing needs? And you've got on the left-hand axis, you've got the score, the Chelsea Physical Assessment, Physical Activity Score, and then across the bottom you've got the patients who went home needing no rehabilitation, went to community support, short stay rehab, long stay rehab, etc. And you can see a really nice, clear decrease in the activity scores as the patients needed more support. So reasonable suggestion of good construct validity there, and certainly a guide to what patients might need. That right-hand group of patients was those who didn't survive from hospital, and they had scores all over the place. At the same time in Sweden, there's been a physical disability instrument just in the first publication. And this one really only looked at, they did a modelling exercise and found 4 predictors of new onset physical disability. But for me, those 4 predictors don't help us in any way because, most of our patients who are having problems have ICU length of stay more than 2 days. There's not a lot we can do about lower educational level, but obviously it tells us the patients that might have problems. So I didn't find that particularly useful, that instrument. Okay, so I can hear you all saying, but we do brilliantly at mobilising our patients. Do we really? This is Point Prevalence Study from the ANZICS CTG Point Prevalence Program that was published last year in Critical Care and Resuscitation, and this work was led by Sue Burning. So on the day they did the point prevalence, there were 498 patients who had sufficient data for analysis. And on that day, and the percentages don't add up to 100% because patients might have done more than one, but we had about a quarter of the patients who had in-bed exercise only. 19% sat over the side of the bed, 37% sat out of bed, 25% stood and 18% walked, which is not too bad. I mean, that suggests that about 2/3 of our patients are getting out of bed. They did a sub-analysis of the 384 patients with a length of stay more than 48 hours. And of those, 86% of them were not walked, so they might have sat out of bed, but they weren't walked. And interestingly, 23% of those that had a long length of stay more than 7 days didn't walk. That suggests there's a group of patients there that we might be able to do something more for. One of the common reasons for not mobilising people is that they've got too many lines in. And so this is some work also out of Melbourne just recently, where they did a feasibility study, a safety study for early mobilisation of continuous renal replacement therapy patients. Just 34 patients, and they had either femoral subclavian or internal jugular access for their dialysis. And they looked at 3 levels of mobilisation: passive bed exercises, sitting on the bed edge, standing or marching. And in this, you can see that the 34 patients, down the left-hand side, 11 patients were judged not eligible for active mobilisation, but they did have passive mobilisation. The other patients, the 23, were considered eligible for active mobilisation, and they had either low or high level mobilisation, and they did include patients with all 3 sites of venous access. Importantly, there were no adverse events, no filter occlusions or failure during the mobilisation activities. Filter life, anyone with an electively discontinued filter was excluded. They did some linear regression that was clustered by the individual patients to account for multiple filters in individuals. And then they did some subgroup analysis based on those 2 factors. But the message was, intervention filters actually lasted longer than non-intervention filters, and the higher the number of daily position changes, it was associated with a higher filter life. Now, this is very small numbers and very early work, but suggesting that continuous renal replacement therapy is not a reason not to mobilise people. And that's just showing again the high filter life for that intervention filter. So what do we know about interventions to improve the physical function of ICU survivors? This is a systematic review from last year, and the conclusion is the telling story. The only effective intervention to improve long-term physical function in critically ill patients is exercise or physical therapy. Its benefit may be greater if started earlier. Further research in this area, comparing different interventions, is urgently needed. There's a little bit of work around suggesting directions that we might go, but not a lot at this stage. And this is again some work out of Melbourne here. And this was the pilot study showing the safety of functional electrical stimulation with cycling in critically ill patients. There was a cycling study out of Belgium about 4 or 5 years ago that suggested it was safe, and this is in some ways a follow-on from that. We've had the protocol published earlier this year, we can see, in BMJ Open for that study, so I look forward to seeing the results in the next couple of years. It might give us some guide. There's also a lot of talk, particularly out of the American literature, about the ABCDE, so the Awakening and Breathing Coordination, Delirium Monitoring Management and Early Exercise. It's often accompanied by these really strong editorials. There's never been an RCT, it's all pre-post studies. And there's really inconsistent work. I mean, most of the interventions make sense, but we don't have good evidence to show that it actually makes a difference. It's a lot like all of the other things that could be good, but may not in certain contexts. There's been a lot of talk over the years about sedation, and one of the wonderful things that's meant to solve all of the problems is daily sedation interruption. I'm really glad I've never been converted because this study supports me. So this is 430 patients in 16 ICUs in US and Canada. And what they found when they put daily sedation interruption as the intervention there was that there was no difference in time to extubation, ICU or hospital length of stay or incidence of delirium. Interestingly, the daily sedation interruption group did have increased daily doses of midazolam and fentanyl, increased number of boluses of benzos and opiates, and the assessment of nurses' workload was increased for those patients on daily sedation interruption. And so what they were seeing was that patients woke up with a start and needed a whole lot of medications to get them comfortable again. A lower level of sedation on a continuous, gradual basis, I would suggest offers a whole lot more benefit from this than this sudden waking and putting back to sleep. So how well are our patients recovering from ICU cognitively? We've looked at the physical function, and again, Ed touched on the cognition. There's a great review done by Wilcox that was published in Critical Care Medicine last year that talks about the risk factors, predictors and rehabilitation interventions. And they propose basically the same model across the care continuum that we've seen before, but what they've done is summarised all of the different factors that suggest where we might start to intervene in this group of patients. And I'm not going to read through all of those. You can find that yourself if it's of interest. But again, we don't have great evidence that all of these matter or all of these might be able to be changed for benefit. It's a beginning start in this picture. So how might we improve cognitive or physical rehabilitation after ICU? And this is just a pilot study of the RETURN randomised controlled trial that's out of the US. And in this, it was a single-site feasibility pilot randomised study, and it was only 21 patients. So it was very much feasibility at this stage. But the results did suggest, so this was a 3-month home-based cognitive intervention, cognitive and physical intervention. It required quite heavy resources in terms of people to visit the patients on multiple occasions over the 3 months. There were about 6 visits over the 3 months, and they went through a range of exercises that were both physical and cognitive in nature. But in this feasibility study, they reported improved cognitive executive functioning and better performance, in other words, a lower score on their functional status measures that they used. So again, that's the feasibility work. We look forward to some results further down the path. How well are our patients recovering from ICU psychologically? So these are 2 papers published that give us results, and again it's out of the US, of both depression and post-traumatic stress disorder. So there's been a lot of studies over the last 5 or 10 years really clearly saying that our patients have lots of psych compromise in the months and years after they leave ICU. And this work says exactly the same. 40% of patients with depression, 24% of patients with PTSD, and you can see the risk factors that we're seeing there. can we predict which patients are having problems with psych, and therefore can we do something about it? So you can see there that the predictors identified in this study are largely not things we can do anything about, apart from maybe screening those who are depressed in the ICU or experience in ICU agitation. If we think about the in-ICU agitation, certainly there's been various studies over the years, and again in the last year or so we've seen the same sort of small, sometimes randomised studies. And this was a study on reflexology, looking at 60 adult patients. They were the long-stay patients, and they showed with reflexology they can reduce blood pressure, heart rate, agitation, anxiety. Does that translate to improvements down the track? We don't know. Similar effective nature-based sounds intervention on agitation, anxiety and stress. Again, very small study, some improvements short-term, don't know if it matters long-term. And the same with music in the ICU. So can we look at some sort of psychological intervention either during ICU or after patients leave ICU? And this work was published actually in 2011, and it's 209 trauma ICU patients, and they had a psychological intervention that was led by clinical psychologists and reinforced by the multidisciplinary team within ICU, and consisted of education, counselling, stress management, coping strategies, and it usually consisted of 5 to 6 sessions per patient and included the family. And at 12 months, so long after they'd left ICU, the intervention patients did report lower anxiety, depression and PTSD. Now, I know of a couple of studies about to start or already going on with the same sort of work. I know in the centre where Mervin's associated with, the clinical psychologist there is leading a study. And so we might see more of this in ICU or early after ICU work from a psych point of view. Thanks. So certainly we need to think about things a bit differently, and this work was published, led by Doug Elliott just recently, but with a group from across the world, where they're saying we need to make sure we're engaging non-critical care providers and also the survivors. And I mean, obviously we can deliver things in ICU, we can work with others to deliver things after ICU, but we can't do it alone because we don't follow our patients through the ward areas and then out into the community. They're suggesting that the work for the future is to look at characterisation of at-risk patients. We need to recognise the risk factors and the mechanisms of injury, and we need screening instruments. And as I showed you, there's a few screening instruments starting to be delivered. And we need both prevention and treatment interventions. Now, having said some of what's out there, what I'd like to leave you with is don't believe everything you read. This is a paper that was published in Science last year, and what it was that a group of people developed a spoof paper, credible but mundane scientific paper with such grave errors that a competent peer reviewer should easily identify it as flawed and unpublishable. It wasn't in critical care, it was in Science. And they developed multiple variations of the same theme. And they sent that paper to 304 journals. 167 of them were on the Directory of Open Access Journals, which is meant to be a group that rates and assesses journals as reasonable. 121 journals were on Beale's list, which is a listing of questionable journals. And 16 were on both the list of good journals and the list of bad journals. And so that's 304 journals that the article went to. 157 journals accepted it, 98 rejected it, and 49 journals, it's still outstanding, the decision, and 29 of those are likely derelict journals that have vanished and they just still had a website. So that's the message, really. This is where all those journals were located, and you can see they're all around the world. It's not unique to one or two places, although there are concentration hotspots. And these lines show you both where the journal's meant to be located, but also where their bank account is that you pay the fee for the open access publication. I will stop there. Thank you.